Thank you so much, everyone, for taking the time to meet with me today. We're going to have 45 minutes of a lecture about sudden hearing loss. And then I will leave the stage for you to ask any questions you have about this condition or any other condition related to hearing or balance. Once again, thank you for taking the time to meet with me. I hope you will enjoy the seminar and you will find it useful. So today's topic is about sudden hearing loss. And let me start by introducing myself. My name is Fadi Najm. I'm one of the academic and clinical faculty at the University of the Pacific, the Department of Audiology in San Francisco, but we are an extended team between both campuses in Stockton and in San Francisco at the university. So let me start by introducing our team. So if you go to the Stockton Clinic, you have Dr. Gale and Dr. Munira. Both of them will take good care of you if you visit that clinic. Dr. Gale is the director of the clinic, and then we have an awesome team that strives to serve you at any time. And then in San Francisco, Dr. Julia Chung is the director of the clinic in San Francisco, and all of us serve as a clinical and academic faculty at the clinic and at the Department of Audiology. Of course, we'll provide you with a copy of the presentation, so you'll have our names as well as the contact information. If you have any questions at any time, feel free to email any one of us, and we'll be happy to answer your questions. Today's agenda will include information about normal hearing and information about sudden hearing loss and information about the symptoms of this condition, as well as the causes of this condition. Then we'll talk a little bit about the audiological evaluation that we usually do to evaluate this condition. And we're going to talk about the critical information related to the treatment. And finally, we'll talk about amplification options for this condition if it fits the patient's case that we'll discuss. Let's start by identifying what is normal hearing. So if you take a look at this ear anatomy sketch, you can see that the outer part of the ear includes the auricle, or what we call the ear pinna. Then we have the ear canal. And then at the end of the ear canal, we have the eardrum right here. And inside or behind the eardrum, you will find the space that we call the top, which is this space right here. And inside the middle ear, we have three little bones that we call the ossicles. And the sound is collected usually by the pinna, and then it's directed inside the ear canal. And as you know, sound is vibration, and the vibration will cause the vibration of the eardrum. And then this mechanical vibration is transmitted through these little bones to the inner ear. And inside the inner ear, you have this snail shape structure that we call the cochlea. And inside it, we have little hair cells and fluids around it. So when the fluid is disturbed, the little hair cells are shearing or moving, and then that movement activates the electrical action potential or the neurological response that goes through the nerve to the brain, and that's how we hear. If somebody has a condition of damage in the outer ear and the ear canal or the auricle of the ear, let's say earwax that occludes the ear canal, then the sound is not transmitted inside. That causes hearing loss. Usually that's easy. We clean the ear, everything is fine. Sometimes we have malformations. The ear canal is clogged by anatomical malformations, and that requires surgery. Sometimes we have fluids accumulating behind the eardrum, causing also hearing loss. It prevents the sound from being transmitted inside. So if somebody has a condition where the problem is in the middle ear or it's in the outer ear, in this case, we call the condition conductive hearing loss because the only problem is conducting the sound inside. But if somebody has a problem in the hair cells inside the cochlea, inside the sensory organ of hearing, and these are sensory cells, then in this case, the sound is transmitted okay, but the sensory cells are not picking up the sound the way they should. And that type of hearing loss is usually called sensory hearing loss. If somebody has a problem in the nerve, we call it neural hearing loss. If somebody has a problem in the sensory cells and in the nerve, we call it sensorineural hearing loss. And that's the most common term that we use, sensorineural hearing loss. If somebody has a problem in the outer ear or the middle ear, as well as a problem in the inner ear, we call it mixed hearing loss, where we have a problem in conducting the sound inside, and we have also another problem in the sensory cells or the neural cells that pick up the sound inside. This is a closer look to the. Let me just, in a second, I need to mute the microphones. Okay. So this is a closer look to what's actually happening inside the cochlea. So if we take the cochlea and we extend it and then we cut it and look inside it, we'll have something very close to what's happening here. We will see three little tubes. The upper one and the lower one have fluid, a certain type of fluid. And then the middle one is completely separated and has a different type of fluid. So we call the fluid in here endolymph and the fluid in the others perilymph. So it's different in its electrolyte structure and balance. But the most important thing is the sensory organ of hearing sits in this middle canal. And if we amplify it, these are the little hair cells. So you can see 4 different rows of cells where you have little hairs right here that we call stereocilia. So when the sound disturbs the fluid inside the cochlea, these stereocilia, these little hairs move and they activate the sensory cells. So if these sensory cells are damaged, we call it a sensory loss. The cochlear structure is very sensitive and it has very delicate blood supply, and it can be affected by different infections, by viral infections, or it can be affected by blood trauma like ischemic issues, like blood flow. So in any case, because it's a very delicate structure, we don't
Excuse me. Somebody has their microphone on and the sound is disturbing. I can't.
Yeah, I tried to mute them all. Hopefully it will work. Thank you. So the cochlear structure is very delicate, and many problems can happen. And it's more than what we usually think. Like a small blood clot can reach the blood supply to the cochlea and cause the problem. It can cause exactly a blood flow issue in the cochlea that can cause damage and can cause hearing loss. A viral infection can hit the cochlea and cause hearing loss. So it's a very delicate structure, and that can cause sudden hearing loss. I have a list of causes that I will discuss with you in a few minutes. So what the ear can do is it can handle different frequencies, different pitches, from 20 to 20,000 hertz. In other words, from very low frequencies, sounds like ah, ooh, ee, these thick sounds, these bold sounds, up to very, very high pitches, like the sounds of the birds, the S sounds, and even much, much higher. Surprisingly and interestingly, we start losing our hearing at the age of 20 and beyond, that young. But we don't feel the effect of hearing loss until later in our life, because hearing loss due to aging usually starts at higher pitches. So it starts damaging hearing at 20,000 hertz, then 19,000 hertz, goes all the way down, but we don't really care about all of these because we don't use these frequencies in communication that much. We care about 500 to 5,000 hertz usually. And that's why, despite the fact we lose our hearing early in life, we don't really feel its effect until later in life when the speech frequencies are affected. So one good number to remember is that 500 to 5,000 hertz is usually the most critical and important range for speech and communication in any language. Then we can handle very wide range of intensities. And we usually measure the intensity level in decibels from 0 to 120 to give you an idea of what is zero. Zero is usually the hearing threshold of normal population. It's the average one. It's the softest sound anyone can hear. 120 decibels is something really loud, like an ambulance siren that is really close to you, like next to you. Speech and communication usually happens around 60 to 65 decibels right here. So that's normal speech. Something like the sound of the refrigerator happens at a soft intensity around 35 to 40 decibels. A jet engine at takeoff, and when you're not standing really close to it, like a few meters away, that can go up to 145. So this is just to give you a sense of the decibel scale. Of course, loud sound can cause hearing loss, but that's a different topic that we discussed in different seminar. The audiogram is our way as audiologists to evaluate the hearing. So it's a diagram that you see here on the screen, where we plot the frequencies on the x-axis and we plot the intensity on the y-axis. And we start from low frequencies to high frequencies, from left to right. And then soft sound is usually at the top and loud sound is at the bottom. Anything better than 20 decibels, that's usually considered in most countries as normal hearing. But when somebody does not hear that intensity, we need to increase the intensity of the sound to make the patient hear the sound. And that means they have some degree of hearing loss that I will show you in a minute. On the audiogram, we plotted few pictures here for you to be able to have a good sense of what is the sound at each part of it. So the sound of the tree leaves is very soft at mid frequencies. It's very, very soft. The sounds of the birds are high pitches, but still soft. Water drops from a tap, from a faucet, is also low frequencies and very, very soft. A barking dog is low frequency at mid intensities, around 60. Something like a motorcycle, a loud motorcycle, can be high pitched and very loud, around 100 and above decibels. You can see the different speech sounds plotted here on the audiogram. So sounds like M, N, B, U, A, E, all of these are considered more toward lower frequency. And sounds like S, Sh, F, and F, all of these are considered as high pitches, high frequencies. This is an audiogram, but it's labeled with the different degrees of hearing loss. So anything up to 20 decibels is considered normal hearing. If your hearing thresholds are up to 40, that's considered mild hearing loss. If your thresholds go up to 55, that's considered moderate hearing loss. If you go up to 70, that's considered moderately severe hearing loss. If you go up to 90, that's considered severe hearing loss. And beyond 90 decibels, that's considered profound hearing loss. So as you can see, the more you go down on the audiogram, the worse the hearing loss is. It's not necessarily that patients would have hearing loss at all frequencies with equal amounts. Sometimes we have more hearing loss at some frequencies more than other frequencies, depending on the condition that caused the hearing loss. For example, hearing loss due to advanced age is usually affecting more the higher pitches. Hearing loss due to increased pressure inside the cochlea can affect the lower frequencies a little bit more. So depending on the condition and the stage of the disease, one can have different effects on different frequencies. Another parameter that we really care about when we talk about hearing and hearing loss is the speech discrimination abilities. So sometimes two people might have the same exact audiogram, the same amount of hearing loss, but when we test their ability to understand the speech they hear, some patients can get better results than others. And we usually quantify it by giving words, a standard list of words, and we calculate how many correct words the patient was able to repeat correctly. So if the patient repeated 90 to 100% correct words, then we consider that as an excellent word recognition score, and that represents excellent health of the auditory nerve. And this is found, of course, in normal subjects and also found in conductive hearing loss conditions, because conductive hearing loss has nothing to do with sensory cells. It's all about conducting the sound inside. So if the sound is loud enough, the patient can pick it up easily. If somebody has a score between 60 and 89%, that's considered as fair to good score. So it's not that bad, but also it's not that good. And we can find this condition typically in a cochlear hearing loss, where the problem is in the sensory cells inside the cochlea. Patients who have less than 60% scores of understanding speech, that's usually considered with neural hearing loss, and unfortunately considered with sudden hearing loss, the topic of today's seminar. So poor discrimination scores is a really challenging situation where we amplify the signal, but the patient still struggles with understanding the speech and discriminating the words that they hear. So it's very typical with nerve damage. And also we see this often with sudden hearing loss or some types of sudden hearing loss. So moving on into the main topic of today's seminar, the sudden hearing loss and what it is exactly. It has different names. Some people call it sudden sensorineural hearing loss, because if somebody has clogged ear canal with wax, that would cause sudden hearing loss, but that's very easy to fix. We just remove the wax. So many physicians and audiologists are very specific about the condition that we refer to, and they call it sudden sensorineural hearing loss or sudden onset hearing loss. This hearing loss happens usually in one ear. Sometimes it happens in both ears, but the probability of that is way less. So most typically we see it in one ear only, and it can happen immediately, like all of a sudden somebody loses their hearing, or it can happen over the course of few days, like very rapid deterioration in hearing in few days. Many people find out about it when they wake up in the morning from sleep, and they can feel that one ear is gone. There is no hearing in it. The problem with sudden sensorineural hearing loss is that it causes significant reduction in word recognition scores, like speech discrimination becomes difficult. So amplification becomes challenging, and I'm going to discuss the impact of that at the end of this presentation. The probability of having that, like the onset of this happens usually every year. The incidence happens between 1 to 6 in 5,000 adults every year. So it's quite high, and men and women are equally affected. There's no difference. And the most endangered age group is between mid 40s to mid 50s. However, it can affect anybody. Like I have patients who had this condition in their early 20s, and I had patients who had it later in life in their 70s. But statistically, studies showed that this age group, 40s to 50s, have the highest risk. So, what are the symptoms of sudden hearing loss? From its name, the symptoms are sudden. So, today you're okay. The next day, something all of a sudden happens to your ear. It's not necessarily related to anything you know. It's not necessarily giving you like warnings before it happens. But many patients reported that they feel a pop in their ear before they lose the hearing in it. So if you're awake and this happens, there's a chance that you would have tinnitus episode and then a pop in the ear and you lose the hearing. But if you're asleep, probably all of this happens and you don't feel it. And the next day when you wake up, um, you would feel the hearing loss directly. And because this condition usually happens in the inner ear, so hearing loss can happen because of the loss of the hearing, people feel fullness in their ear. And because the inner ear also contains the organ responsible for balance, some people have some dizziness symptoms. And because hearing loss and damage to the cochlea can cause tinnitus or tinnitus, um, some of the patients report having tinnitus after the loss of hearing, and it continues. So it's not necessarily that patients will have all these symptoms. Hearing loss is the main one, but we can have these other symptoms as well. It's very typical that people discover it in the morning, as I mentioned. So most people wake up and they realize that their hearing is gone in one ear. If it's not that severe, many patients discover it when they use the phone and they start noticing the difference between both ears. The problem with sudden hearing loss is that it's a medical emergency and we need to act very quickly to solve the issue. So we're going to talk about that. So if you discover the problem early enough, that's great. But if you don't, or if you discover it and you don't react and go to the physician immediately, then that would be problematic. And I will explain why in a few minutes. Before I go into that, I'm going to discuss with you and show you some causes, some common causes for sudden hearing loss. As I mentioned, the cochlea is very delicate organ, very, very delicate. Like the cells are very delicate, the blood supply is delicate. So anything can affect its performance. So infections in general, especially viral infections, can hit the inner ear and can cause sudden hearing loss. So if somebody has labyrinthitis or neuronitis that can hit the inner ear, which is an infection, a viral infection, that can cause and lead to sudden hearing loss. Head trauma and accidents. So some people fall and then probably blood clots and other other conditions related to accidents can lead to physical damage to the inner ear compartment. Another common cause that requires a lot of studying in research is autoimmune diseases. So sometimes the inner ear is attacked by the defense system of the body, and then that can lead to hearing loss. Sometimes exposure to certain drugs, like we take a medication, one of its side effects is damaging the hearing. That's why it's really important we don't take medication without prescription and without the follow-up with a physician. And we need to know the exact side effects of medications. Common medications that can cause this problem, like aminoglycosides, gentamicin, kanamycin. It's antibiotics, strong antibiotics. If they're given with high dosage, they can lead to hearing loss. And some of the chemotherapy medications like cisplatin and its derivatives can also lead to toxicity in the cochlea and lead to hearing loss. However, of course, there is balance between life-threatening situations and the need for the medications versus the risk of hearing loss. And they usually happen a little bit gradually. But when we say sudden hearing loss, we refer usually to the first three conditions: infections, head trauma, autoimmune, and I would add the fifth one, which is the blood circulation problems. Like it can be a stroke, it can be a small blood clot that clogs the very delicate and small blood vessels in the cochlea. So the infections, head trauma, autoimmune conditions, and circulation issues are the most common causes for this. There are some other conditions, such as Meniere's disease, which is the increase of the fluid pressure inside the cochlea. And the increase of that fluid causes a physical damage to the cells. And that can also lead to eventually a sudden drop in hearing loss. But most patients with Meniere's disease, they discover the condition before that. And if they get appropriate medical care and they follow the instructions, they usually can avoid it. Other conditions such as multiple sclerosis, it's a neurological condition that affects different parts of the nervous system. If they hit parts of the nerves, the fibers or the nerve neurons that um, stimulate the cochlea and are connected to the cochlea, then also hearing loss can happen. What do we do for evaluation for this condition? Well, the bottom line is sudden hearing loss is a medical emergency and must be treated as medical emergency. The reason for that is the treatment efficiency is really high within 24 hours. So if somebody has sudden hearing loss and they get the appropriate treatment within 24 hours, there is a high chance that can go up to 90%, depending on the study that you're referring to, but it's really high, a chance of restoring the hearing. The problem of waiting is that the chance of recovery decreases beyond the 24 hours. If somebody gets the hearing loss, does not realize it, or does not react and go immediately to the physician, then the treatment is delayed and the chances of recovery is reduced. The longer we wait, the lesser the chance of recovery. So immediately once we realize somebody has sudden hearing loss, we need to do a hearing evaluation and a medical evaluation. The hearing evaluation includes otoscopy, which is the tool that we use to look inside the ear canal to exclude anything clogging the ear, or let's say earwax or perforation of the eardrum or any external infections. And then we do pure tone audiometry, and that is done to evaluate the degree of hearing loss, like what we explained on the audiogram. And then we do speech audiometry to evaluate the ability of the patient to discriminate the speech. And then we do also what we call tympanometry to evaluate the middle ear condition to see if there is any infection in the middle ear that can cause that. Because if it's a middle ear infection, that's usually an easy fix with medication at the physician's office. But if it's a sudden hearing loss that hits the cochlea, that's a different route of treatment. Then if the patient is suffering also from balance issues due to the problem that happened in the inner ear, then we need to do balance testing. And then the physician can order some blood tests and some imaging to exclude different etiologies or different conditions. So how is the sudden hearing loss treated? I have this in blue because if there's a take-home message from today's presentation, it would be this line. If you experience sudden hearing loss, it is a medical emergency and you need to seek medical help immediately if you experience sudden hearing loss in one or both ears. The reason for that is it's time sensitive for treatment. The medical treatment that the physician would offer is very effective within 24 hours of incidence. But if you delay the treatment, if you don't get the treatment early enough, the chances of recovery is reduced. And the longer you wait, the less and less the chance. So ideally, we want you to get the treatment within 24 hours. Let's say that the physician applied the treatment, and usually the treatment is corticosteroids. It can be provided orally with high dosage, and it has to be monitored by the physician because this is a not this is a medication that the dosage really matter and its side effects must be monitored by the physician. Sometimes it's provided orally. It could be in syrup form or tablets form, or sometimes it's provided and injected through the tympanic membrane. Many physicians I know prefer to do the intratympanic, like through the eardrum. They just inject it because they avoid the side effects of the medication, and the speed of reaction is quick. If the physician applies the treatment for the period required, and then there was no recovery, then the patient needs hearing aids or cochlear implants, or sometimes different options for amplification. So what are the amplification options for hearing loss that is sudden and permanent? It could be a typical hearing aid with any style, depending on the degree of hearing loss. So hearing aids are usually divided into two main groups, a group that is called in the ear. And in this case, the hearing aid, all of the hearing aid sits inside the ear. And then the other group is considered behind the ear because there is a part that goes behind the ear and then a little piece that goes inside the ear. So in the ear hearing aids, they can be really small, such as this one. It's called completely in the canal, or CIC. Could be a little bit bigger like in the canal or ITC. Could be a little bit bigger like half shell ITE or in the ear. Or it could be filling all the concha of the pinna of the ear, and that's called full shell ITE. Of course, it's more visible. For the hearing aids behind the ear, it could be powerful for profound hearing loss, where we have this part behind the ear and then we have an ear mold sitting in the ear. It could be a little bit smaller, which we call standard BTE, that still uses an ear mold, and it's used for, let's say, severe to profound hearing loss. And then it could be mini BTE, and there are two types of mini BTEs called slim tube, where we keep the speaker of the hearing aid right here, and then this is a slim tube that transmits the sound in the ear. Or it can be where we divide the speaker and we put it down here inside the ear canal, and then we connect it via a wire to the main hearing aid behind the ear. This is a very famous style of hearing aids. It's called receiver in the ear, and it fits many patients. Not necessarily this condition, but many patients love its performance. The technology level, this is a big topic, but think of the hearing aid like computers. So all computers have, let's say, a keyboard, a screen or monitor, as well as the hard drive. Some computers cost $200, some computers cost $10,000. The difference is not in the components, it's in the performance. So what the computer can do. Of course, the more advanced, more expensive computer can do way more calculations and better performance in different applications. So the hearing aid does the same thing. Our standard is normal hearing. So we are trying to mimic normal hearing as much as possible. And normal hearing is more complicated than we think usually, because we think of hearing as there is sound or no sound. I can hear or I cannot hear. But it's actually way more complicated. If you just think a little bit about it, if two people are talking at the same time, you can focus on one person and ignore the other person. That's called selective hearing or selective attention. And that's a very complicated process through the neurological pathways in the brain to achieve that. And another example, if you're listening to somebody talking in a noisy environment, for example, the brain or different stages of the neurological pathway to the brain actually filter the noise out and enhances the sounds that you want to hear and understand. So hearing is really complicated, it's very selective, and it's very intentional in many situations. So the hearing aid is beyond just making the sound louder. So if I go back to many years ago, like 20 years ago, we didn't have all the good technology we have today, and hearing aid technology was basic at that time, and the quality of the sound was not satisfying to many patients at that time. And we were saying to patients, you have to live with this quality of sound. Nowadays, we are living in a golden age of amplification. We have excellent technology in diagnostics and excellent technology in hearing aids, and we are helping 95% of our patients, and we are providing outstanding hearing experience. So we go toward more advanced technology, more premium technology when we want to achieve more natural hearing, and we want to bring the patient closer to normal hearing quality. Of course, the worse the condition, the more advanced technology you need. So, for example, if two people have the same hearing loss, but one of them has really poor speech discrimination and the other one has really good speech discrimination, we will need, we have to provide more advanced technology for the one who has poor discrimination, because we need to compensate for many things. We need to provide more or better quality to make listening effort less. So it depends on the condition of the patient as well as the needs of the patient. So I have this slide to understand why do we need higher technology with some patients. So we need higher technology if somebody has more listening demand than others. Sometimes the type of job that we do requires a lot of attention and listening. For example, I am a university professor. I need to hear my students in sometimes small rooms, sometimes big auditoriums. So I have a huge demand on my hearing in my work, and I need more advanced technology to help me with these complicated situations. And this leads me to the next point, which is the environment complexity. If somebody has or spends most of his time in quiet environment, talking one-on-one to one person, they usually don't need that much advanced technology. Can you hear me okay? Okay, because my picture froze. If you can't hear me, please let me know. So the environment complexity, the listening environment complexity is another factor. So if somebody spends most of his time in quiet environment talking one-on-one, they don't need that much advanced technology. But if someone is very active in terms of changing environments, so they talk to crowds, they spend time outdoor and indoor, they have meetings, they go to restaurants a lot. So all of that, it changes the complexity of the environment, and the more complex the environment, we need more advanced technology. And the complexity of the environment leads us to the next point, which is the lifestyle. Usually people who, so if we forget about the work, some people have an active lifestyle, like they do a lot of activities, and they have different listening environments because of their active lifestyle. So the more active the lifestyle, the higher the technology you need. Sometimes patients have academic demand, like school kids or university students, and they have academic demand. And because of that, because of the importance of that, they need higher technology to guarantee their access to all the information they need. Another factor is for little kids who are still acquiring language. So if there is a language acquisition demand, such as early years of life, then we need a higher technology to also allow for better access to technology. Now, all of these are related to the patient's lifestyle. On the other hand, the hearing loss itself can also decide. And this is what I mentioned before. So if somebody has worse word recognition score, in other words, their ability to understand speech is less, then they need more advanced technology to help them compensate for that. And the worse the hearing loss, the worse the discrimination ability, the higher technology we need, and the more we need oral rehabilitation, and the more we need wireless accessories to help the patient in different situations. So, having all of that said, there are also other options besides the regular hearing aid. There are options where we do what we call a cross system. In this case, if somebody has a dead ear on one side, like there's no hearing at all, and the other ear is still okay, we can provide a system that routes the signal from the bad side to the good side. And that way we compensate for the lost ear. Sometimes we can provide a bone conduction hearing aid for those who have malformations and they cannot use a regular hearing aid. We can provide amplification through the bone, and it could be wearable device like this one. It could be an implanted device like this one, or in some cases, we can go to cochlear implants. If the cochlea is the damaged part, we can provide a device that sits inside the cochlea and takes over its function. Having that said, I want to highlight the challenge in sudden hearing loss. These are three examples of sudden hearing loss cases. So all of these patients have normal hearing in the right side, but they had sudden hearing loss in their left side. The one on the left side, number one, there is no response. Almost everything is lost, and the word recognition score is 0%. In other words, the ear is gone. With this one, some frequencies here are completely lost, but there is some residual hearing right here, and the discrimination ability is 24%. So it provides us with three-dimensional quality of hearing. It's very natural because wherever they talk to you from any side, you still can hear. And then it provides better speech discrimination, especially in noisy environments. It is very important for sound localization. It provides more distinct sound quality. So, for example, speech sounds are identified in a better way when you use both ears. They are way less stressful and way more enjoyable to use both ears. And all of us hear music in both ears, not in one, because we enjoy the quality of the sound. And then stimulating both ears keeps both ears active. And that's very important because if one ear goes bad, we ignore it, we don't use it over the time, it gets worse. And it's not necessarily that the hearing loss or the hearing level go down, but the discrimination ability can go down. And finally, if somebody has tinnitus, then we definitely use to address tinnitus in both ears if it's present in both ears. So in summary, the take-home message is that sudden hearing loss can affect any one of us. It's more common in the 40s and 50s of age. It's a medical emergency. If that happens, take an immediate appointment with a physician, do the hearing test, and get the medication needed. That way, you increase your chances of recovery and treatment. So, having all of that said, I would like to thank you all for joining me today. I apologize for the technical inconvenience. It was a that Zoom on my computer stopped working suddenly. And thank you for being so patient and staying online. I was really worried that when I come back, nobody is here. So thank you so much for staying online. And if you have any questions, you can ask me now. So I will give you time to ask me any question you want. And then if you can think of any other questions later, please feel free to call us or email us. We will be delighted and happy to talk to you. I now will receive your questions. Feel free to unmute yourself and ask.
I have a question. I'm not sure if you can hear me because I'm new at this.
I can, yes.
My husband was diagnosed with this. It happened February of last year.
Mhm,
And it was just like you said, it was immediate. The next day we figured out he was deaf in that ear. And then he had the loud, like buzzing noise, and then he couldn't sleep. He stopped eating. You know, he's a really stable person, but everything just went terribly wrong.
mhm,
And immediately got into the doctor, and our doctor is very good, but he just thought it was an ear infection, so they did the antibiotics, and then they did we went back and did the drops, and he was just getting worse and worse because of the loud noise.
mhm,
So I finally got him to the ER, and of course nowadays the ENT, it was a month out, and you know they don't believe you that it's a medical emergency, because and so the ER doctor got him right in, and the ENT in Sonora said, I think I know what you have. So, and he was right. And so we did the steroids orally, but it was 2 weeks after by the time we finally got to this guy.
mhm,
And then they did the steroid shots over like, I don't know, 7 weeks, 3 weeks apart and all that. Nothing worked. And so we go to Dr. Gale down at UOP, and she's been great with the hearing aid, and that helps him. But he's still, the biggest challenge is not that he only has half the hearing, because you can kind of work with that, but it's the noise, that it makes it hard for him to sleep. And so now he has to take Ambien, and then it's caused stress and anxiety. And this is I mean, my husband's a retired school psychologist, so he's a pretty stable guy, but it's just been life changing for him, and of course for me. And I wondered if you had any ideas of how to deal with that. I mean, he's done the white noise, and we do the fan and all of that, but it's been tough.
I totally understand, and thank you so much for sharing your story. It always has more powerful impact on what we're talking about.
Hmm.
I totally agree with all what you went through, and I
Hmm.
see that challenge when you try to schedule an appointment and they say it's not a medical emergency. I like
Yeah.
to talk about this topic a lot because I usually save somebody by educating them about this condition,
Yeah.
because patients need to insist on seeing the ENT, specifically the ear doctor,
Yes.
immediately as possible to increase the chances of this to work. As you mentioned, after 2 weeks, no matter what they try, the chances of recovery is slim. If
Yeah.
they got to him within the first 24 hours, or at least the 48 hours, the chance of restoring at least some of the hearing was high. So I totally see your point. Unfortunately, it's a problem in the medical system in the US in particular, because
Yeah.
everything goes through referral. And
Hmm.
sometimes the person who refers you, it's not necessarily that he realizes how significant the time is for that particular condition. So the take-home message, and thank you again for the story, is to distribute the word. If it's sudden hearing loss, even if the PCP decides to just give you ear or treat it as ear infection, it's critical that we see the physician. So having
Yeah.
that said, tinnitus can be accompanied by this condition, and it could be very dramatic, and also depends on the cause, like what actually caused the sudden hearing loss. Autoimmune
Hmm.
and Meniere's disease, and blood circulation issues, they usually cause the most tinnitus, accompanying tinnitus, and it can be really, really bad. Now, what can we do? The first thing is live healthy as much as you can. That means try to be hydrated, take antioxidants, be relaxed as much as possible, and eat healthy, play sports. So, all of these, believe it or not, play a critical role in handling tinnitus. Now, number two, tinnitus can be very, very annoying. And I do understand when patients say, I cannot ignore it. However, it's a cycle of stress, sleep, and tinnitus. So, having tinnitus increases the stress and disturbs sleep. Increasing the stress and disturbance in sleep increases tinnitus as well. And it's a vicious cycle of this that continues to happen. One good advice is do whatever you have to do to get good sleep and ignore it and try to relax. I know it's tough, but breaking the cycle can help. Now, the other thing is um, hearing aids itself, the hearing aid itself plays a significant role in distracting the patient from the tinnitus. And let me explain three different strategies that we use. If the tinnitus is not that loud, we just increase the ambient noise through the hearing aid and that covers it. If the tinnitus is really loud, like let's say 30 decibels of perception or more, then we try to distract by providing a melody, a pleasant melody in the background. You know, when you go to a shopping center and there is a background melody happening, you like it,
Yes.
not bothered by it, you still can function. So we can provide something like that if it's too loud, where it blends with the tinnitus and distracts the patient from the tinnitus. If it's somewhere in between, like it's not too loud but not too soft, then we provide a masker that makes the patient hear a little bit of the tinnitus, but something else as well. Over the time, the perception reduces of the tinnitus. Then we take the masker down, and then we make the patient hear the tinnitus again a little bit. And over time, the perception reduces. We keep repeating that over a year. And at the end of the year, when it gets really soft, if it gets to the point that it's really soft, then we cover it with the ambient noise. If it remains, the option is for the patient at that point to continue with a melody to distract or to cover it with whatever sound they want. This is what's happening right now. But again, tinnitus is a symptom, not a disease. So if we know the underlying condition that causes that, then we might be able to do more. With the sudden hearing loss, unfortunately, the damage is permanent. So I would recommend keeping, since he's using a hearing aid, I would recommend forcing himself to rely more on the hearing of that ear, and that can restore a little bit of the function and force the neurons on that side to act in a better way.
Okay, and Dr. Gale had just talked to us yesterday about starting the masking part and the other noise. He tried that in the beginning, you know, like 5 months into it, and it was a disaster. It was over in Sonora, and he just hit that ear, couldn't tolerate anything. I think it was just so ultra sensitive, and anxiety was so high. But things are better with medication, and he still golfs now 3 days a week and does the different exercise. I mean, he's been, you know, he said, you know, I wanted for shoes until I met the man with no feet, and this is the hand that I'm dealt, so I have to just make it work. So
one other thing I would like to bring your attention to, there are some studies that you heard about the gut-brain connection, right?
yes.
Okay, so there are many nutritional facts and factors that can affect our hearing and our hearing health. So usually lactose intolerance, gluten sensitivity, high sodium intake, cholesterol, high cholesterol, etc. All of these can play a very detrimental factor into hearing. So my advice is to, and they can happen at any age, by the way. So one good advice that we're giving to everybody at this point is that check your diet and try to find the connection between whatever diet that hurts your hearing or increase your tinnitus. If you find that connection, then adjust your diet. You see what I mean? So
Yes.
ask him to pay attention to what he eats, and if he eats something that he finds causing an increase in the tinnitus, then he should reduce that.
Okay, that's good information because we're kind of old hippies, you know, we're in our 70s and we've always eaten pretty organic and healthy. And, you know, we have ice cream now and then, but it's now and then. But that's interesting because some days he'll say the noise is worse. And, but we never thought about, well, what did he eat that might have been
Yeah.
connected? So we'll start looking at that.
Yeah, that would be a very interesting and good advice, because we're seeing more and more of that connection.
Okay. Well, thank you very much. We
You're
we
most
knew
welcome.
nothing about this topic until it hit, and we think his was that circulation, maybe blood clot thing, because he woke up in the middle of the night and said, you know, my head's rolling on the left-hand side, and then it went away and we went back to sleep, and then he woke up deaf.
Yeah.
And so that's when it kind of all started. So we've learned a lot, but I'm glad you're educating people because you know, we have a really good doctor, and this other guy we saw was really good, but I don't even know if they know about it because, you
Yes.
know, they knew he
That's
was
true.
deaf, but they didn't like say go to the emergency room. And thank you, Jesus, that we met a PA there that understood it and begged the ENT to get us in. Of course, it probably didn't matter because it was 2 weeks out by then, but at least we got some answers.
Yeah. And believe me when I say I personally and all of us as audiologists, we're trying to push towards not education the public only, but educating the primary care physicians and those who
Yeah.
actually make the referrals, because they need to know that this is a medical emergency that makes a big difference in treatment. But
Yes,
the law,
yes.
and it takes a long time for lawmakers to listen to us.
Yes. Yeah. Yeah. Well, if you ever need me to give information about our story, because maybe, I mean, I feel kind of bad because I felt like I did everything I could because I just saw him deteriorating. I've known him forever and I've never seen this kind of thing happen, you know, and I knew I had to do something and I wish I had done it fast, but we did all we could and you can only do so much. But I knew at the ER, I told him, I said, if they don't help us here, they're going to have to call the police because we are not leaving this ER
Yeah.
until we get some help because there's something wrong. But I guess we stay away from doctors, nothing personal, but you know,
Yeah.
as much as we can. But I knew something was drastically wrong.
Yeah.
So, okay. Well, thank you very much. I
You're most welcome.
appreciate the work all of you do, and UOP, they've been wonderful. Dr. Gale and Cherry and Iris. I mean, it's a wonderful support system for us.
Thank you so much. We're here to help,
Yes.
and it's always a pleasure actually to help all of you as much as we can.
Yeah. Yes. Well, thank you very much. Have a good day.
Thank you. Any other
Bye-bye.
questions?
Doctor, hello?
Yes. Hi.
Oh, I'm Miss Perry. Does the hearing aid stop the ringing in the ear? How do that two go together?
Yes. Now, the ringing in the ear, it's a symptom, it's not a disease. So the first step would be to identify the cause that led to the tinnitus. Sometimes the cause can be treated. For example, if there is a certain infection that caused the tinnitus, we can treat the infection. But sometimes the tinnitus becomes a permanent symptom due to hearing loss or other central issues. If the tinnitus becomes a permanent issue, then it wouldn't go away. However, the hearing aid can provide one of the solutions. For example, if the hearing loss led to the tinnitus, then providing a hearing aid will stimulate these hearing impaired regions of the auditory system. And that kind of reactivation helps you hear the sound around you again. And that by itself covers the tinnitus and helps the patients. However, on the other hand, some patients can have really bad tinnitus where it's really loud, and just providing the hearing aid by itself wouldn't solve the issue. In this case, we have to quantify how bad is the tinnitus. If it's really, really loud, then we go with the philosophy of providing a distraction. In that case, the hearing aid would provide a pleasant melody in the background that matches the tone of the tinnitus, and that brings you or takes away your attention from the tinnitus. And over the time, that can make you ignore it more, and your perception of it becomes less. In other cases, the tinnitus is not that loud, and we just provide some sort of extra amplification at ambient noises around you, and that covers over the tinnitus. So we can treat it, not treat it, we can handle it in a different way depending on its severity. So the advice is to use the hearing aids if you have hearing loss, to talk to your audiologist about the tinnitus, because most probably they can program the hearing aid in a way that can reduce the perception of the tinnitus. And finally, because as I mentioned a minute ago, it's a cycle of stress, sleep disturbance, and tinnitus. So tinnitus leads to stress and sleep disturbance. Stress and sleep disturbance increases the tinnitus. We have to break that cycle. So the more we relax, the better sleep we get, the healthier we live. All of that helps in the tinnitus.
And because since I've been wearing the hearing aids, I don't have the noises anymore. So I guess that's a good thing.
That's an excellent thing. So in many, many patients, the tinnitus is a symptom due to hearing damage. So once we provide amplification, we are forcing these damaged regions to work again, and we are helping the patients restore the hearing of these sounds that they didn't hear anymore. And that by itself makes them overcome the tinnitus.
So is it once you start wearing the hearing aid, you always have to use it? Could the ear hearing ever improve?
Well, it's a hearing aid. It's not a hearing treatment. So as long as you have hearing loss, you need hearing aids to use them to hear. It's like when somebody needs glasses, without the glasses, they don't see well. With the glasses, they see well, but the glasses, they don't improve the vision over time. However, not using the device. So if you don't use, for example, your glasses over the time, your vision gets worse. The same thing happens in hearing. If somebody quits using his hearing aid, over time, the brain ignores the bad signal and the hearing can deteriorate. It's not necessarily that the hearing threshold itself would get worse, but the speech discrimination, we know for sure that over time it gets worse if we don't use the hearing aids.
So I never had any treatment. I have never had any medication. They just gave me the hearing aids.
Depends on the condition, yes. So if it's hearing loss that is permanent, then hearing aids are the solution. But if there is a condition that caused the hearing loss and they have a treatment for it, they would give you the treatment. Yes, depends on the cause.
So I won't get any treatment.
It depends. I'm not familiar with all the details of your case and when you had the condition, but based on data, all subjects beyond the age of 65, they start needing some sort of amplification. So just advancing in age can lead to deterioration in hearing, and all of us at some point would need a hearing aid. Yep.
Now, you're an affiliate of the UOP on Fifth Street.
Yes. So on the 5th Street in San Francisco. Yes.
Yeah. Oh, okay. Because that's where I've been going. Okay, I enjoyed this today. Oh, I know. All the statistics and the numbers that you gave,
Mhm.
we have no way of knowing what our numbers are. Only the doctors know that. they never told me what level of hearing I'm at, like the
Well, if you
statistics.
go to the audiologist, and so if you're referring to the audiogram numbers, the audiologist will explain to you the details of your hearing level and the type of hearing loss, all of that. And I'm pretty sure if you ask any question about your hearing health, you will get the answer for sure. Now, regarding
Well,
statistics about, let's say, the incidence of a problem and so on, it depends. Some people say it, some people don't discuss it. It depends on what the physician or the audiologist feels useful in that limited time of the session.
like you said, 20 dB is like normal,
Yes.
and
So,
yeah, 90 is bad loss,
yes,
and have to do with age, I guess.
yes,
But
it's right here.
I never knew about those
Mhm.
statistics before.
Yes. So these are the classifications of the degrees of hearing loss, and we explain to individual patients the degree of their hearing loss. So we would say you have a moderate hearing loss or severe hearing loss, and so on, case by case, usually.
So I guess I already lost it. Oh, no, what about implants? Do implants comes after hearing aids, or should it come first?
No, they come last. In the case of sudden hearing loss, where the discrimination is really bad, we try with hearing aids first. If we fail, if we cannot restore the hearing to the point that people enjoy it for communication, then we would look into other options. In other cases of hearing loss that is not sudden, most patients benefit from regular hearing aids. And if they do benefit from the regular hearing aids, we don't go into cochlear implants. So cochlear implants is the more expensive and a little bit more effort solution. And we don't go there unless we really don't have the other options available.
Okay, thank you.
You're most welcome.
Enjoyed this. Have a little more, have more information that could, when you go to the doctor. I didn't know a lot of this. So
Well,
you
I'm
can't
glad
ask,
we helped. I'm glad we helped.
yeah, you can't ask questions about something you don't even know.
Yes, and that's the key point of these seminars. We're trying our best to provide useful information to our patients.
Because you said like from 0 to 59 is poor, 90 is bad, and 20 is good.
Yeah, right here. And we'll provide you
Yeah.
with a copy of the presentation with all these numbers.
So if you had a blood clot, something like that could affect your hearing.
It can be poor, and that's the problem with sudden hearing loss, that many patients who have, not all of them, but a lot of them, would have poor discrimination after a sudden hearing loss, sudden sensorineural hearing loss. Yes. Any other questions?
Oh, thank you so much.
You're most welcome. Thank you.
I like that one. God gave us 2 ears.
Yes, for a reason. Yeah.
So you can lose in one and not in the other. Yeah, oh, yeah, I kind of noticed that one ear's a little better than the other.
Yeah.
Yeah. Same thing with your eyes. You can have a good eye, you can have
Sure.
a bad eye. Yeah. Okay, thank you so much.
You are most welcome. Any other questions?
That's good for me. Oh, somebody's talking, but the person is muted. Mary Anderson is talking, but I can't hear her.
Mary, if you have a question, please unmute your mic and we can hear you.
Oh, I wasn't talking. I was just writing a thank you in the chat.
Oh, thank you so much.
Oh,
Thank you
I
so
thought
much.
she was-
Well, if
All right.
you don't have other questions, I will give you the rest of your day back. And once
Why you put that up there?
once again, I would like to really, really thank you for being here today with me. And again, more thank you for being patient with the technical difficulty we had when my connection got lost. So thank you for staying. I really appreciate it. If you have any other questions, feel free to contact us or email us anytime. We are here to answer your questions. Thank you so much. Have a good day and take care. Bye, everyone.
Thank you. Bye.
Thank you.